All right, so today's topic will be about opening your eyes to dry eye. Here are some quick disclosures and my associate, Dr. Claudia Unani. So educating colleagues and the public or patients is really important to me. So here are some contributions we made to dry eye awareness and education and different publications, from Review of Optometry to Modern Optometry to different news outlets. Pre-COVID, we were featured on the Doctor's Show. We were educating on a national level about dry eye, MGD, and using tear care as a advanced thermal expression treatment. Really important when we talk about dry eye. A lot of celebrities are coming out openly and sharing their journey. Most recently, we had Jenny Garth visit our practice for OptiLight, and we'll have a short clip of that towards the latter half of the video. She's amazing. It's wonderful when patients come in and they think that they're the only one, but we're able to share that depending on the reference that you use, there are 30 to 50 million Americans with dry eye disease, and that there are celebrities such as Jennifer Aniston and Jung, who played in Hangovers, who's also a physician, Marissa Tomei, and Kyle Richards. When chatting with patients, we try to simplify things as much as possible and connect the dots for them. So when we talk about dry eye, we let them know it's a complex condition. It's not something not something that we can cure them of, but we should properly identify, diagnose, and treat these patients early, so that way we can get them significant improvement, and that way it doesn't interfere with their daily activities or quality of life. The main goal when we're treating these patients is to improve the consistency, quality, and stability of their tear film, most notably by reducing microbial overgrowth, unclogging the glands, and managing inflammation. So we'll also discuss how OCULUS is a very important, the OCULUS Keratograph is a really important part of our workup protocol. When patients come in, they may complain of different or various symptoms. So they may think that dryness might be grittiness or burning, but really all of these symptoms here can be a form of dry eye, including if they have a chalazion or a stye because of blocked oil glands. But the most common reason patients will visit our practice is because of blurry or fluctuating vision. Those patients will be refractive. We'll ask them to blink. Does their vision feel better? They'll oftentimes say yes. And if they're emmetropic, it's a real telltale that it's the tear film that needs to be addressed. The patients that we screen now is essentially everyone, but I'll have colleagues ask me, well, where do you start? And these are a lot of patients in your practice currently that you can kind of address these issues and then probe them, and they may turn into a dry eye patient. So if they're overwearing their contact lens patients in general, certainly if they're overwearing them or they're in reusables, patients, male or female, who are wearing cosmetics, especially eyeliner, mascara, false lashes, we want to watch out for those glues, and a lot of toxic ingredients that can be in these different makeup brands. Patients nowadays during COVID are using computer use extensively, so we want to make sure to remind them to take blink breaks, the 20-20-20 rule, and different visual ergonomic techniques such as computer screen at arm's length below eye level, remembering to blink, take breaks, have both feet firmly planted, and not to be hunched over. Autoimmune conditions, you can look out for these patients. What's really interesting is that patients may say that they don't have rosacea, and rosacea is a form of an autoimmune skin condition, but we can see rosacea of the eyelid 20% of the time it develops in the eyelid, rosacea does, before it hits the face. So we can oftentimes be the first provider to capture that from patients or diagnose those patients. We also want to look out for certain medications. Accutane can be really tough on the meibomian glands, and for dry patients, birth control. Common ones that we might know are antidepressants, blood pressure medications, such as diuretics. But a great one that I recently have kind of delved into is statins, which we'll talk a little bit about later, or patients with high cholesterol. And of course, during this time period with COVID, increased or prolonged face mask wear is something that we should look out for. We've seen a huge incidence and prevalence of dry eye disease as well as dyes during with these patients. So we mostly touched on the contributing factors, but some of the ones that I may have missed are refractive surgery, humidity, low humidity, vitamin deficiency, and if they're not blinking properly. So with cosmetics, not only the ingredients, but how they apply the makeup and making sure to remove it. So there was a great study that came out. Regular use of eyeliner in the waterline can significantly lower tear breakup time, leading to evaporative dry eye, as well as cause structural changes to the glands and increase the presence of telangiectasia. Also, tattoo eyeliner is something else to mention to your patients to stay away from, or can be a contributing factor for some eyelid disease. Our glaucoma patients, about 63% of them have dry eye, so we want to make sure that we're staying on top of that, whether it's because of the preservatives in the medications that they're using or because of the actual active ingredient. Here are the most common ones that we prescribe for glaucoma patients. Most notably, prostaglandins can actually, are most likely of these to cause MGD. But as you can see, adrenergic agonist, can increase allergies. The CAIs can affect corneal thickness, and then the beta blockers can act in the lacrimal gland. Cataract patients. To improve our cataract patients' post-op outcomes, we want to screen these patients, especially if they're having any kind of keratitis on the ocular surface. Look at their topographies and see if there's any abnormalities or irregularities. Overall, you just want to look at the big picture. The cardiologist, the primary care physician, doesn't just look at blood pressure disease, blood hypertension, and ignore diabetes, thyroid, and high cholesterol. They'll make sure to address each of those conditions. So same thing here. We want to make sure that we're taking care of any comorbidities, and patients oftentimes do present with anterior blepharitis or Demodex. They'll present with clogged oil glands. They may not be they may have incomplete eyelid closure. They may have some eye allergy. So I'm one of those patients who has dry eye as well as eye allergy. So you want to address both conditions so we get the patient to feel better sooner. You can also look for, again, internally within your own practice at keratoconic patients, and we listed some of the others already. So how do we evaluate for dry eye? Here's the keratograph. It's kind of our go-to for diagnostic imaging. Very important. We'll go over how it measures tear meniscus height, non-invasive tear breakup time. It takes high-definition images of the ocular surface, including conjunctival injection of redness, and it also can pick up on buildup plaque biofilm of the eyelids, as well as telangiectasia, leading to diagnosis of ocular rosacea. And one of the most important is infrared imaging for meibography. So this is kind of how we break it down when we talk to colleagues. We want to have a standardized dry questionnaire. Using your vital dye staining with fluorescein and lissamine green is very important. You can use a meibomian gland evaluator in the photo in the bottom right here, or you can use digital expression with your finger or Q-tip. So you can get as high-tech or low-tech as you like. But as I mentioned, the keratograph and other modern imaging tools can be very beneficial, including tear osmolarity. So this is more or less the SPEED2 standardized questionnaire that we use in the office. The OSDI works beautifully, the EQ5 as well. We also like to give this to our dry consult patients. It's a dry disease questionnaire, and it basically goes over what types of demographics the patient comes in with, any kind of medications that they're currently on categorically that may lead to dry eye, as well as any other pre-existing diagnosis, such as autoimmune diseases or other infections, and the most common symptoms they might be experiencing. From these questionnaires, we can really kind of differentiate and triage which patients will do best, whether they're coming in for a comprehensive exam and then they can transition to a dry consult same day or at a future visit. We basically can triage and see if these patients would benefit from a further workup. Here's a great example of using the keratograph for fluorescein staining. You can see kind of before and afters. Fluorescein pattern using the keratograph, patient with SPK. Here's a great one where you can see the Demodex buildup, the classical collarettes on the left there, as well as lid wiper epitheliopathy. I think one of the ones that's really underutilized in eye care is lissamine green, but we use it commonly in conjunction with fluorescein. And it tells us a lot of valuable information. Of course, it picks up on desiccated cells on the ocular surface, but if you kind of invert the lid, both upper and lower, you can pick up on this dense, thick, hyperpigmented presentation. And you want to address both components, not just the lash line, not just the bulbar conj, but also looking at the lid margin and seeing if there's anything of concern. Meibomian gland evaluator tells us a lot of wonderful things as far as the function of the meibomian glands and if the patient may benefit from treatments, both lid exfoliation, home hygiene, and or any kind of advanced thermal expression in the office. Let's see. So we'll have some more meibomian gland expression videos here. So once you kind of go through diagnosing the patient, you can actually use the MGE, you can use gentle meibomian gland expressor. This one, I believe, is the Ledoux forceps, or we kind of mix it up between Ledoux forceps. And most recently using the TearCare clearance device has been really gentle on patients, gentle yet effective. And patients love these videos. Oftentimes they request us to send the videos to them. I believe these are just with a slit lamp adapter, but we also have the Firefly, which takes great binocular. We can look into the scope oculars while we are expressing the patient in the slit lamp. So that was just kind of showing what abnormal function of meibomian glands are as well. So new imaging technologies are valuable tools, not only for disease assessment, but also patient education. The ability to properly guide the exam journey from the diagnostic testing to treatment plan is imperative for optimal outcomes and patient satisfaction. So patients oftentimes may see 3, 4, 5 different practitioners before they find the treatments that will give them ultimate relief or maximal relief, but connecting the dots for them is really important. So having these types of imaging devices where we can look at meibography can really help as far as understanding what's going on and letting them know if there's anything concerning, which we'll jump into in just a little bit. So here are some of the modern ways that we check doing meibography again, topography, fluorescein staining analysis, imaging those and being able to show them to patients where the visual satisfaction is fantastic. Taking those anterior segment photos, showing them their tear meniscus height, lipid layer thickness, as well as blink rate. So how do we explain this to patients? We try not to be very technical. So we tell them that, again, what we're checking when we do these different images are, do you have inflammation? What's the saltiness of your tears? That would be tear osmolarity. What are the quality, consistency, and stability of your tears? So when we're checking things like non-invasive tear breakup time. Is there any bacteria, biofilm, or plaque that we need to address? We're going to look at the structure and function of your eyelids and the oil glands within the lids. And we also want to know, are you sleeping or are you blinking fully when you're on screens or when you're in bed? The action of blinking actually activates the muscle in order to push the meibum out. So if they have these pseudo or half blinks, that's going to be really problematic. Okay, so one of the big ones that we utilize one of the big reports that we utilize is the crystal tear report. So it's very easy. It takes a technician just a few minutes to perform, and then the practitioner goes over it with the patient as far as what is going on and what we need to do. So we look at tear, and it does it in a way where we can grade the patient and we can track things through time and show them the differences. So they get excited oftentimes once they have their treatment and they come back for their post-treatment follow-up. We're able to show them that the non-invasive tear breakup time graph on the upper right has improved to mostly green. Or immediately after, before and after doing a BluffX treatment, showing them that all the Demodex plaque, the collarettes, are essentially wiped away. Being able to show them that their tear meniscus height has improved. And also showing them that there's stability in their gland structure. Or counter to that, if they don't have treatment performed and we see progression or further loss of meibomian gland structure, that oftentimes motivates the patients to move into treatments. So here's the format where the patient, we can print this out or email this to the patient as far as what are the tests that we ran, a little bit of background or explanation on what they were, what conditions they have, such as meibomian MGD, inflammation, aqueous deficiency, as well as some of the recommendations that we can make for them, whether it's home care or escalating, if it's concerning enough, directly to office-based treatments. So here's kind of a summary of how the recommendations may look. Here's a patient that on the left, you can see that the first three, that left upper column, are home routine, compresses, omega-3s, and lid cleansers or lid hygiene. And then you can see that this patient would also benefit from lipoflow, thermal pulsation, from Optilite or IPL, and then from a microblepharoexfoliation. So there was an article that I wrote a few years back on the importance of different meibographers, and there's kind of a nice overview of LipoScan, LipoView, the Keratograph, and the MeiBox. And we ultimately decided to go with the Keratograph for many of the things that we'll be chatting, that we talked about and we'll continue chatting about. So here's one of my favorites. So the LipoScan is great. It's quick. It works really well, has great photos, but this is the Keratograph where the top image is showing us the patient's meibography images, but the unique thing about the Keratograph, the K5M, is that it not only takes the patient's results, but we can compare it against normative data or grading scale. So the bottom portion is where the grading scale is. On the left are normal meibomian glands. Then we kind of go to mild changes, moderate, and advanced changes. And up top is where the patient falls, where we can see some dropout and recession of glands. On the bottom left, you can see a patient who has essentially 80 to 90% gland loss or truncation. So for someone who comes in looking like that, who we haven't seen, maybe as a first-time patient or is the first time imaging their glands, that is very concerning, especially if they're in their 20s, 30s, 40s. It's very important to take care of some of our older patients, take care of all of our older patients, but we commonly have pediatric patients that come in with these types of glands. So we definitely want to address this as quickly as possible, as well as image the upper lids to make sure that there's still structure available, or anatomical meibomian gland anatomy is still available. So here's some great before and afters with the Keratograph. So patient on the left, before and after BlephEx treatment, literally 10 minutes after. We had a patient just on Thursday or Friday of this week who asked to have the treatment done same day for BlephEx, but also wanted to see the images afterwards, and she was just blown away. So she loved seeing that. The middle image is a patient who went through a series of IPL or Optilite treatments, and you can see that essentially whitehead is gone. I believe that was after 4 sessions. And again, on the far right, you can see a pretty gunky, a lot of plaque buildup before BlephEx and after treatment. So the diagnostics are really great because we can transition the patients from this is what's going on to we need to do a treatment in a very short period of time. So they can visualize that and understand what's going on. Let's see here. So alternative to the Crystal 2 report is the GenVis report. It's a little bit modified. We traditionally use the Crystal 2 report, which we upgraded to, but we previously would use the GenVis report. And so that's just an example of what the layout is. We like the Crystal 2 report because it breaks it down into green, normal, yellow is mild, orange is moderate, and then red is more severe, advanced. And then patients can kind of see that scale hopefully improve over time as they do their office-based treatments and or home routine. This is just showing an example of tear meniscus height and how the patient had extremely low tear volume or aqueous deficiency. This is using the Keratograph's lipid layer. Here's some other ones before and after for a patient who had Optilite treatments. You can show them how the conjunctival injection on the left improves over time. to the picture on the right, same patient, but better kind of presentation and reduction. Not immediate, of course, and not complete resolution, especially of the deeper vasculature that you can see along the left lower part of the image and then the right upper on the bulbar conch. And so that's kind of the diagnostic side. And then we use that information really valuable in order to transition into or convert the patients into kind of a treatment plan or treatment protocol. So we follow loosely. This is a great reference early on, but as you become more comfortable and experienced and seasoned in taking care of these patients, you customize these to the best of your abilities. And so this is a loose outline as far as how to follow things. And so if they're kind of mildish patients, educating them and letting them know what environmental factors are affecting and lifestyle factors they can maybe modify or adjust, as well as home regimen works nicely. If they're not improving or their symptoms don't resolve, or if they persist or worsen, you want to escalate, you can go to pharmaceuticals. For those who listened to my lectures in the past, I'm not a big fan of pharmaceuticals as first line unless the patient needs maybe a pulse of Lotemax or Isuvis to calm things down. We're not quick to jump into punctal plugs. Of course, plugs have their place. There's no inflammation, the glands look good, and it's mostly aqueous in nature. Plugs look fantastically. But oftentimes there's some component of MGD or inflammation going on, and so we'll reach for the office-based devices that you can see, things like LEFX, thermal modalities, and light therapy, or photobiomodulation. You can continue to escalate to scleral lenses, autologous serum, and then we are huge fans and have had great success with placenta-based drops for Generize. And then continuing onwards, the patients aren't improving your amniotic membranes. We prefer using cryopreserved or Procera. We kind of took a shot at dehydrated and didn't see results that were as satisfactory as a cryopreserve. So we just continue to lean into the Proceras. And very infrequently do the patients need to have any kind of surgical procedure. So for optometry, this steps 1 through 3 and part of 4 falls into our wheelhouse, and we're able to take care of 90+% of these dry patients, especially if we catch them early on. There are a lot of treatments available in therapeutics, especially modern, and this is not an exhaustive list at all, and it's missing things like TrueTear should actually be off the list and replaced with Tyrvaya. But we can see that there is an extensive list. Meibomian gland probing is another one that can work really nicely for patients who are not benefiting or not improving with combined office-based modern devices as well as home routine. So this is kind of how we break it down. This is our kind of algorithm, if you will, as far as if the patient has any kind of anterior, posterior blepharitis, we'll do the deep cleanings on the left-hand side. If they have any kind of obstruction, we'll go to the middle column. And then if they have any kind of rosacea, we'll lead into the left column. The ones that are in large are the ones that we commonly do. The ones that are in bold and have a larger text here. So OptiLight works really fantastically. 4 sessions, about a month apart. We can close the gap between visits if the patients are more advanced, and we can make them about 2 weeks apart. So it really just depends. If a patient is leaving to Singapore at the end of this month, we started seeing her in November, and she would like to get all of her 4 sessions in before she leaves the country, likely permanently. So we're going to try to get those in safely and effectively. OptiLight also has some really great benefits where we can see regeneration of glands, and the meibography images before and after with the keratograph comes in really handy. The patient was excited and thrilled that we could see better visualization and possibly regrowth of the glands. So she continues to have her maintenance session. So great, again, for educational purposes to have these advanced diagnostics. So we've been treating patients in our Advanced Dry Eye Center for many years now, and our home routine and office-based routine continues to evolve. So these are some of the things that we specifically lean into for patients as far as their home routine, depending on what's going on. The Hyaluronide ointment by Optase recently became available in the States. Prior to that, it was available on Amazon. We'd have to send patients there to purchase the product, but great vitamin A ointment, especially for patients who are waking up in the middle of the night with dry eye or in the morning. So asking them, what time of day do you feel worse is a great question as far as morning, afternoon, evening, so they're waking up in the middle of the night. Of course, the patient has nocturnal lagophthalmos. Having an ointment at night, especially this one, has been really great for our patients, and it's also preservative-free. Supplements can come in handy. As I mentioned, Regenerize, compresses, autologous serum drops for those patients who want blood drops. And there's some talk about PRP being a little bit better than autologous serum drops or AST drops, so that's also an interesting conversation. We've become huge fans of the iTear, which is a neurostimulating external device that goes on the nose. And it works very similarly to Tearvia and TrueTear that was discontinued, but it's done externally. There's no chemicals involved, and we're able to demonstrate in office with the patients how that works. And we've had a lot of good success with patients who demonstrated, converted to purchasing them, and then also sharing their feedback at follow-up visits, being less dependent, using the neurostimulation device and being less dependent on lubricating drops. The interesting thing about neurostimulation is it's not just creating reflex tearing and aqueous, water component of your tears, but it's also creating basal tears and getting the meibum pushed out of the orifices. Lid hygiene, really important. We want to control the bacterial overgrowth or any kind of Demodex. And proper cosmetics, Eyes of the Story, are the ones that we really enjoy using because they have a commitment to staying away from toxic ingredients, formaldehyde, parabens, and many others. Blood tests and blood workup. So as we're trying to improve the patient's quality of life and reduce the symptoms of flare-ups, the frequency and severity of flare-ups and episodes of dryness or ocular surface disease, making sure that we don't have any holes at the bottom of the bucket is really important. So having the patients run tests for inflammation, autoimmune, and lipid panel, and vitamin deficiencies can be very beneficial. There was a recent article in Review of Optometry that showed patients with history of statin use have an elevated risk of dry eye disease. But the patients also found that in the article, they also mentioned that patients that had lipid abnormalities could also be at a risk, have a risk factor of dryness. So paying attention to our patients and what medications they use and things of that sort can be very helpful. An important one to not dismiss is if patients say that, oh, I use eye drops and something over the counter, is kind of tuning into what they're saying and making sure they're not using drops that come in a bottle, come in a vial, especially if they're using them multiple times a day. So they're not introducing preservatives onto the ocular surface and causing harm over time. It's that compounded effect. So we always gear towards preservative-free drops. And if they have MGD, we go more towards things like Retain MGD, Oasis, Optase that have a little bit more of a lipid component to it. Sustained hydration PF is also great. Refresh, Relieva as well. So a lot of the companies are doing a good job with that. And they can come in a bottle if they're preservative-free bottle, but many still come in the traditional format. So just a little bit of background as far as how we approach patients from a boutique concierge type practice, marketing standpoint, customer service, and technology. These are many of the things that we really focus on. So we really spend the time with our patients as an advanced dry eye center. So if you're looking to kind of take that approach, and we are an advanced dry eye center who also happens to do primary eye care, but we really emphasize and prioritize our dry eye patients, and they can take up a lot of time. So we can't stick with a 15-minute model. Some of these patients, when they come in for their consult, especially if they're visiting from out of town or out of state, we try to schedule their consult and treatment in the same day. So they might be there for a couple of hours. So you may have to bring in a new provider or adjust your scheduling in order to accommodate these patients, especially if you're going to be doing office-based treatments. taking care of them, asking them to share their experience, whether it's online or taking photos with them. We will oftentimes take care of our dry patients and give them complimentary gifts and things of that sort. We'll share these success stories on social media with their permission. We'll post photos. And they can see that our team is really passionate about taking care. This is what we really enjoy doing, and taking care of them makes a huge impact on their quality of life, but also is really gratifying for us, especially as a personal dry eye sufferer myself. And they'll oftentimes say, we have one who's sending her mom in for the holidays, who's visiting in town. We have another one whose father is visiting from out of town. So when you take care of these patients, they will share that with their family members. In fact, dry eye is a very has a genetic component to it. So letting them know, do your parents complain about dry eye, or have your kids mention that they get eye fatigue on the computer with online learning. And screening those patients can be very valuable, especially catching them early if they have signs and no symptoms. So we want to make sure that we prevent them from getting to this point where they have the symptoms that are on this list here, from itchiness to watery eyes to styes and contact lens discomfort. So having these kinds of educational posters, videos, infographics, before and after images to be able to share. We have an iPad Pro that we'll share with patients as far as chalazions before and after with the pre and post treatment. So those come in handy. And most recently, being able to share that you're not alone, that you have public figures that are sharing their stories. So Jenny Garth, again, is an iconic TV actress who was on the traditional show, or back in the day, the legendary show Beverly Hills 90210. So she conveniently went from Beverly Hills 90210 to Beverly Hills Optometry. Play a short clip of the video.
Hi, such a pleasure to meet you. Happy to have you here. So tell me a little about your backstory.
Okay, well, I have irritated eyes all the time. Like when I wake up, you would think I've slept all night. My eyes should be fresh as a daisy, right? I wake up, my eyes feel dry. They are very sensitive to any kind of air blowing, and someone recommended that I check out this Optolite, and I didn't know anything about it, so I found you, and I want to hear all about it.
Optolite has been fantastic in our practice as far as giving patients relief. So hopefully over the course of the next 4 sessions, you'll start to feel some improvement.
She's a much better actress than I am. So we were also, again, on the doctor show. We picked this patient, Ivani, who continues to come back for her tear care treatments every 6 months. So it's like clockwork. It's a great video, too, that we can catch on YouTube. So recently we had a patient who was referred by her daughter who lives in New York. The patient lives here in LA, and she had been struggling with dry eye for some time, and she was starting to lose hope. Unfortunately, she had brain cancer that she's now in remission for. She has, switch the summary of the article, has hypertension, thyroid disease, diabetes, high cholesterol, which thankfully are controlled medications, but she had cataract surgery in her left eye. She wanted to have cataract surgery in her fellow eye, but because the best corrected vision was 20/40, but the surgeon wouldn't proceed because she had such bad tear film. Her tear film evaporation was almost instant. And so he was concerned to proceed with cataract surgery. The patient had no improvement or relief with punctal plugs, over-the-counter drops, and lid hygiene techniques, and she'd been experiencing this for about 14 months. So here's the power of taking care of these patients and performing office-based treatment. So she came in with speed scores of 24 out of 28 and tear osmolarity scores of 335 and 333. Within 6 weeks, her tear osmolarity score dropped 30 points, which is tremendous. That's huge. She started to already feel a little bit better. Her speed score dropped, a nice amount, but not as significantly as we'd like. But after 16 weeks, and there was a little bit of, we lost each other due to life happening and other doctor's appointments, but she had 2 additional Optolite IPLs, and her speed score dropped to just amazing 0 out of 28, which is fantastic. So that was only with 1 BlephX, 1 LiquidFlow, and 3 IPLs or Optolites that it dropped down to 0. And she still had her 4th session about a month later, and she most recently came in for her 3-month 3-month visit, and she's pleased, her surgeon's pleased, and they're going to proceed with cataract surgery. So she was thrilled by that. It was just a scheduling issue for her and the surgeon. The surgeon's been really busy with surgeries and scheduling. So we'll go over a couple of quick cases. We're kind of winding down here. Patient, LASIK, post-op, about 15, 16 years or so. We saw him, I believe, in about 2020, 2019. But pardon me, this must have been before COVID, so 2019, early 2020. And he was using Opcon-A drops just over the counter in a bottle and thought he was doing himself some good. He had some mild dryness, scratchiness, and burning. After one LipiFlow session, he did fantastic, and I don't think he's needed anything since. Here's another patient who had not very much, minimal symptoms, just some end-of-day fatigue and dryness, but he wears his comfortable contact lenses all day long, so that might protect him like a bandage contact lens. So he may not be as aware. He does have blepharitis. We did do some early BlephX treatments, but he's doing a great job with home care, and his lids have looked fantastic. He's had some triasis where we've done some epilation, but you can see that his glands, there's some concerning loss of his glands at the bottom left. And you can also see in the upper right that his non-invasive tear breakup time, his tear film stability is significantly reduced. After one LipiFlow session and 2 months later, we can see his side-by-side non-invasive tear breakup times with the keratograph. Huge improvement. Again, even though he wasn't feeling very symptomatic, we could see signs of dry eye disease and ocular surface disease, and to show him the improvement, it was fantastic. And we both got our thumbs up there. Great success story for him. Lovely IPL patient who actually had a speed score of 19 out of 28. Looks like that's in the wrong section where it says signs speed score. But she was experiencing severe dryness, grayness, irritation. History, she had had LipiFlow in the past, scleral lenses, doesn't wear makeup because of her dryness. She tried Avenova. She sleeps well, uses a humidifier. She was negative for autoimmune, including Sjogren's. She had temporary plugs, BlephX, sleep masks, all the works, pharmaceuticals. And not until we got her in for IPL treatments did she start to feel improvement. She's a dancer. She wanted to be out of contact lenses. And sure enough, we were able to get her to a place where she was stable. She wasn't really thinking about her eyes. She was able to have refractive surgery smile with one of our local refractive surgeons, and she's doing great ever since. And she continues to come in regularly for her maintenance sessions. Here's a patient who had MiBaFlow, who we're not performing as much of anymore because a lot of our patients enjoy having, if we're going to do thermal treatments, having the disposables and replacing those, disposables and applicators with LipiFlow and iLux and TearCare. They prefer the more hygienic approaches with those. And then I've had my fair share of medical and ocular history with keratoconus, MGD, ocular allergies, Crohn's disease, and then most recently with kidney failure and transplant. Back in failure was September of 2019, and transplant was in March of 2020. Thankfully, everything went really smoothly and doing well. The hard part was being away from patients during the height of COVID, but I'm glad to say that we're back and really love what we're doing, so I really miss that. And so I've been on a number of different therapies over time, and I've experienced my dryness for over 20 years on and off because I was diagnosed with Crohn's when I was about 15, 16 years of age. And about 10 years ago, I was able to get my first office-based treatment with BlephX, and then slowly that's evolved. LipiFlow is not ideal for keratoconic patients. I just wanted to test it and see how patients would feel with the applicators in their eye, but I do much better with things like IPL and iLux and TearCare. Here's a 27-year-old female patient who came in with anterior blepharitis and some irritation and redness of her eyes and contact lens intolerance. And with one Zest treatment, which is by Zocular, ZocuKit treatment, the patient started to feel significantly better. In fact, there's some work with Zest and contact lens patients and how it can increase the comfort by up to 4 hours. So your patients who are wearing a great daily single-use contact lenses, MyDay, Daily Total One, Acuvue Oasis, etc., who are still experiencing irritation or discomfort, it's most likely not the contact lens because the contacts are extremely hydrating, sterile, single-use. It's likely the ocular surface foundation that needs to be addressed. So she was one of those patients who did really well. Procera works beautifully for some of these patients, again, before and after, to be able to show them. I believe, again, this was with the Keratograph, be able to show the patient before and after images of a patient with blepharitis. And so you can see the Oculus, the Keratograph gives us really high definition images of the eyelid surface, and you can see the ocular rosacea just kind of screaming at you. All the broken blood vessels of the telangiectasia, the severe, significant telangiectasia that you can see. And so that inflammation can cause the tear film not to flow as well. And so with treatments, IPL, she was the Procera patient, and with advanced thermal expression and infrequent lid exfoliations in office, her tear film has improved, her non-invasive tear breakup time has improved, and her ocular rosacea has also calmed down as well, and she's feeling a lot better. Let's see, let's keep moving. This one's really important. So taking images of the lower lids, meibography images of the lower lids is important, but a great takeaway is that when you're examining them and doing meibography and the patient may not be very symptomatic, you want to look at the upper lids and see what's going on. So the lower lids are pretty much wiped out. There's not a whole lot we can do. The upper lids are still available, present, accounted for, and that's probably what can help a lot of patients who may not be symptomatic. So flipping the lid, inverting the lid can tell us a lot of extra information. You want to make sure you're not missing that. Here's that the doctor show patient. And so just like clockwork, she comes in. Her first one on the doctor show was January 2020, and then every 6 months since. And we have her scheduled to see her in January of 2022, which is mind-blowing to say, for her fifth round of tear care. Let's see. Here's the patient from earlier. He was a 46-year-old male with Demodex blepharitis, MGD, and ocular rosacea. And here's immediate before and after with the Keratograph as far as how his base of his lashes look. So really powerful. And Optilight has been really good to a lot of our patients. So the patients are experiencing maybe symptoms. We do the testing. We move into treatment. We're able to compare the before and afters. And it's just a really gratifying process, and these patients become raving fans. So we love those thumbs up. And it's been an absolute pleasure. We'll shift into Q&A. Any of y'all are interested, happy to answer any basic questions or high-level questions. There's no bad questions, whether it's with colleagues or with patients. So happy holidays for those who are going to kind of dial off, but I'll stick around for a little bit, here for about 10 minutes to answer Q&A. That's a great way to email us, and then we're also very active on Instagram, and that's our handle. So thanks again.
All right, thank you, Dr. Silani. Just a reminder, on your GoTo webinar screen, there is a text box where you can enter any questions you may have. If you miss part of the webinar, or if there's anything you would like to go back and review, you will receive a link to the recording in the next week. All right, we do have quite a few questions for you. We do have somebody who's asking, eye makeup worn during treatments. I kind of wanted to build off that as well and ask, do you have the patients just come in normally as they would just kind of their regular day routine wearing makeup, or do you ask them to remove their makeup for just even dry eye screenings and treatments?
Yeah, so if they're coming in, it could be the end of the day and they're coming from work, it's really straightforward. We just remove the makeup in office. We have eyelid wipes from Tear Care. It can be really from any brand, but we have Eyes of the Story wipes. We have Optase wipes that we use, depending on what the patient presentation is. But whether they're wearing it or not, some of the patients come in with false lashes, and we show them the images with the keratograph about, the Demodex and all the gunk that's going on. And immediately they tell us, let's take off the makeup, let's do the treatment today. I don't want to wait for my next refill to come back in between refills to see you. Let's just do it right now.
Okay, we do have quite a few questions about makeup, like what makeup did you say you recommend? And also, do you find that any particular maybe ingredients in cosmetics cause more symptoms of dry eye or irritation?
Yeah, so eyes are the story is what we carry in office and we recommend to patients. They have a great philosophy to take out some of the top 10 ocular offenders, so things like BAK, which we're familiar with as a preservative in eye drops, parabens, formaldehyde, retinols, retin-A's. If patients are using things like tretinoin, retin-A's, you want to make sure they're staying away from the goggle area. Very important. So that can dry them out. But eyes are the story. Fantastic product that we've used. They have a great eyeliner and mascara. Unfortunately, they only have it in black at the moment, but they'll be coming out with more colors and eyeshadow and other things in the near future. They launched during COVID, which is also a female started brand. So we like to support our practice. As you can see, is very female oriented. So we like to support our female entrepreneurs.
Great. So this person's commenting, I might be jumping ahead, but if you get a significant score on your dry eye questionnaire, do you do more examinations than you would with just a screener, or do you just stick with the screener?
I feel like the screener gives us a lot of information. We'll sometimes go a little above and beyond because we share cases, whether it's for articles or presentations like this. But and as you get more comfortable, just by hearing the patient, I kind of get a good idea of what's going on. You're mostly performing these images and tests in order to show the patient that the treatments are working, that there is an issue that we're seeing and that we need to address. And oftentimes, when we catch it earlier in the disease process versus later, we can get them back to baseline. But if we kind of let that linger, it becomes more challenging. So if the patient may have needed 4 visits for OptiLight, if we caught the disease in the mild to moderate stage, if we can show them that there's an issue going on, if we catch it later in the disease process, they might need 4 to 8 sessions. So with time and with comfort, you kind of hone into, okay, I know this patient's going to need this treatment, or this patient's going to need that treatment, or this home modality. But we still like to have the data and the imaging in office, so that way we can show them, even if they're not necessarily progressing symptomatically as quickly as we like, that we can see signs of improvement.
Great, thank you. Do you work with many Sjogren's patients?
Yeah, so Sjogren patients we deal with a lot of autoimmune patients. So Sjogren's patients, interestingly, can have aqueous deficiency, but also they can have meibomian gland dysfunction. So if they tell you or you diagnose Sjogren's, don't just think that it's a lacrimal gland issue. It can also be a meibomian gland issue as well. Was there a follow-up question about the Sjogren's?
There was not.
Okay.
All right.
But we do see, and oftentimes the patients may have dryness. We have them run those blood tests that we mentioned, like ANA, rheumatoid factor, HLA-B27, and we send that to their primary care or to run those tests. And if there is something that's abnormal, then we want to make sure that we're addressing a systemic issue, because we're going to do what we can taking care of the eyes, but we want to make sure that there's nothing else that's impacting or slowing down their progress.
Perfect. What could you do for a 23-year-old gamer with almost no working meibomian glands? Can't regenerate the glands, can you? That's what they're asking, but you did show with the one IPL image that you were seeing some regeneration as well.
Yeah, so there was a more recent article I wrote for Review of Optometry on controversy of gland regeneration, and so there's some early evidence that IPL can help with either visualization, which is pseudo regrowth or true regrowth. So IPL, LipiFlow, Regenerize, the placenta-based drops may help, and then meibomian gland probing. So if there's truly any kind of, if there's complete loss or they're down truncated to about less than 5 or 10%, they might be a good probing patient. So if you can find somebody local, Dr. Steve Maskin is over in Florida and he performs that. So he mentions that 2 out of 3 MGD patients may benefit from probing, but in our experience, it seems like it might be a little bit less than that, maybe closer to 20 to 30%. Just depends on how the patient presents. But yeah, there are things that can be done for those patients. It's the counter to that as well. There are some patients who have significant loss and atrophy. I mean, just mind-blowing, but they feel nothing, which is really remarkable as well. But for that gaining patient, younger, I think IPL will be a great option for them first. If that hasn't been performed, kind of get their home routine in check as far as high-quality EPA products like PRND3. And then if that's not improving, considering probing.
Great, thank you for that response. Okay, our next question is, how much time do you block off for dry eye evaluations? So let's say like a full workup versus a screener.
Yeah, so if they're already there for a comprehensive or contact lens exam, we may add an extra 15 minutes or so to that process. If they're coming in specifically for a dry consult, I think an hour is beneficial, especially because these patients may want treatment same day, or they come in with a lot of questions. Some of the patients that we see have thick records they come in with from other institutions or other practices they visited. We had a patient fairly recently who had seen 18 doctors before getting to us, another one who had seen 10 doctors. I had one last week who had seen 5, more commonly it's between 3 and 5 doctors. But I think giving yourself adequate time frame, especially if you're doing some of these other tests, is beneficial. And having a great team, your front desk, your medical assistants performing a lot of these things, handing out the dry questionnaire, going over lifestyle, going over medications, can help you out as much as possible. But the patients really want to hear from the doctor as far as recommendations on what's going on and how to make them feel better and how to get those glands functioning better.
Thank you. In your home routine treatments list, which treatments do you find to be the most cost-effective for your patients?
So I'm really proud of Regenerize for having 2 separate formulas now. They used to have a Pro, which was very expensive. It was about $195 to the patient, and then more recently it's about $150. You can carry that in office, or you can write a prescription and they can just send it to the patient. But they just came out, that was a Pro version. They have a light version now that is about half the cost to the patient. It's about $80 or so, $75, $80. So that's great for those patients who really need an anti-inflammatory, who are maybe steroid responders or didn't respond well to Xiidra, Restasis, Cequa. But cost-effective wise, the lubricating drops, preservative-free, your Oasis Optase works great. We put together a dry kit for the patient where they have a compress, they have a lubricating drop of our choice, a lid hygiene, such as Avenova, and then an Omega. Hydri is a little more cost-effective than PRN, but there's varying, they kind of get to the same endpoint, but through different means, and we have them both as alternatives in case the patient doesn't do well with fish oil, even though their reesterified triglyceride is of high quality. So we try to have options on everything because there isn't a silver bullet for patients to improve with. This is the only lubricating drop that works, or this is the only omega-3 that works. This is the only lid hygiene. We've oftentimes had patients who say, I hated this product, and then we switch into something else, and they go, oh my God, I love that. So it's nice to have a few different options to go over with them.
Are you doing the grading in front of the patients, or do you do it before you present to the patient?
It depends. So if we're kind of running around, we get busier, then we'll do it while they're there, which doesn't hurt. And sometimes it's nice to say, okay, these are your glands. This is the grading scale. Where do you think you fall on the list? So getting them involved in the process isn't a bad idea. some patients are, we do the test, they go, whatever you say, and so they don't want to even look at the images. But most patients, I would say, especially if they're really involved in their care, they just want to know what's going on and be a part of the process. They want to have the images sent to them. We have patients who, because of our concierge boutique component, we have a concierge line they can text us. During office hours, they can call us. And then if it's more involved, they can email us. So we try to be as available as possible. So it's kind of like with surgeons, if a patient's having LASIK or cataracts and they have any kind of post-op or post-treatment questions, we want to address those.
All right.
So one more you want to throw in?
Sure.
Bonus question.
What is your GoTo Exams with the Keratograph 5M?
Yeah, so my favorite is the myography, hands down, with the grading scale. But the crystal tear report makes it really easy for the tech to just click that button as a quick screening, and then it's going to perform tear meniscus height, which tells us if there's aqueous deficiency. It's going to do non-invasive tear breakup time without having to put vital dyes in. It can tell us how quickly the tear film's evaporating. It's going to look at high-definition images of the ocular surface, including the lids and conj, and of course, myography. So it's going to do those 6 tests, and then our tech will go in and maybe have the patient close their eyes to check if there's any buildup on their lash line. We also want to show them if they're using makeup in the waterline. So when we do those high-definition images, the patient will be the first to say, if they're sitting at the device when we're going over the results, like, oh my God, my eyes are so red, or oh my God, I can't believe my makeup is floating around in my tear film, or all kinds of various things, or oh my God, I can't believe I have mites on my lashes. So showing them those visuals is really powerful, and most of the time they don't want to go home knowing they have collarettes or mites on their lashes and they want to get that treated same day. So it's really great to have those tools like the Keratograph to be able to show them baseline information and then show them immediate before and afters, whether it's anterior blepharitis, or show them over time the changes that are happening to their meibomian glands or to their tear film stability.
All right. Thank you, Dr. Silani, for that great presentation. That's all the time we have for tonight. Thank you for everyone who sent in questions, and thanks everyone for joining us. And thank you so much, Dr. Silani.